Can you guys hear me? Okay, good. So we're going to get started with cardiac masses. So when you're confronted with a cardiac mass in the echo lab, the first thing you want to do is try to define the mass. What's the nature of the mass? What's its location? What's its mobility? What's it attached to? Do you believe it's benign or malignant? Do you actually believe it's a true mass? Clinically, masses may present in several different ways. They may present from obstruction, to inflow or outflow. They may directly involve the myocardium, which may lead to myocardial dysfunction or arrhythmias, embolic symptoms, or constitutional or systemic symptoms, or they may be just incidentally found. The primary modality to identify and characterize cardiac masses remains echocardiography. It allows for us to define the location, the mobility of the mass, and also there's a huge database on recognizing these masses. We have to recognize also, though, that we live in the era of multimodality imaging, and echocardiography cannot answer all of the questions. So we may need to employ cardiac magnetic resonance, which may give us more assessment of spread within the heart or outside the heart, vascularity, tissue characterization, or cardiac CT. So the differential diagnosis of mass lesions within the heart could include normal anatomical variants, which we'll go over in a moment, planted devices, thrombus, which is the most often encountered intracardiac mass, vegetations, tumors, whether they be primary to the heart or metastatic, and artifacts I will leave to Dr. Levine in his lecture. So here's a long list of anatomical variants. I'm not going to run through them all, but in the left atrium and the left atrial appendage, you may see pectinate muscles, which can be confused with a thrombus within the left atrium, the warfarin ridge. I'll show you an example of that. In the right atrium, when I was a fellow, we got a lot of referrals for TEE for right atrial masses that turned out to be a very prominent eustachian valve, as shown yesterday by Susan, mobile Chiari network, or the crista terminalis. And remember also to look beyond the heart, and I'll show you some extra cardiac masses at the end of this lecture. So here's just some examples of some anatomical variants. Here's a TEE, we're in the left atrial appendage, and the arrows are pointing to prominent pectinate muscles. Short axis transthoracic view. This is the warfarin ridge, the Q-tip, or it's really known as the ligament of Marshall. This is the left atrial appendage, which Susan showed you nicely yesterday, and the left upper pulmonary vein. Here in the right atrium, you see this filamentous, highly mobile linear structure, which is most characteristic of a Chiari network. And just sometimes these structures can be involved with pathology. Here's a case we saw many years ago in the operating room. This is a Chiari network on still with small arrows. And you can see a mass coming off of the Chiari network, which turned out to be a thrombus. Implanted devices could include pacemaker leads, defibrillator leads, catheters within the right heart, occluder devices, prosthetic valves and clips, and will include foreign bodies that migrate to the heart. So here's an example of a Amplatzer septal occluder, properly placed, TEE. This is the left atrium and the right atrium. And I just point out this right here, this ridge. Here's the bicable view, superior vena cava. This is the crista terminalis, which is a normal anatomical variant. And below that, or anterior to that, is the very shallow right atrial appendage. In this four-chamber view, you can see pacemaker leads coming in through the superior vena cava, this lead going to the right atrial appendage, this lead crossing the tricuspid valve to the apex. But also remember that these pacemaker leads can be involved by pathology. Here's a patient that we saw many years ago who had an infected knee prosthesis with Staph aureus. The knee was drained repeatedly, and she had surgery to clean that out, but she was still persistently bacteremic. And you can see that on this pacing wire, here's some artifact, see two masses which were highly mobile, which were infectious lesions. Thrombus is the most common intracardiac mass, and it's usually found in characteristic locations. So within the left ventricle, it's highly associated with large anter-apical infarctions. Even in the current era of rapid reperfusion, it's estimated that between 4 and 15% of patients who have a large LAD infarction with apical involvement may have a thrombus present. Also, with patients who have dilated cardiomyopathy, increased incidence of thrombus is found. Often it's layered at the left ventricular apex. Many times echocardiography may not see that, and it may be better seen by cardiac magnetic resonance. The differential diagnosis of apical masses is listed here. The left atrial appendage is a very common place for thrombus to form, obviously, in patients with atrial arrhythmias. And in the right atrium, thrombus can be seen in relation to catheters which enter the chamber, pulmonary embolism, as shown by Dr. Rudsky. I'll show you another example, and rarely within the right atrial appendage, much less common than seen in the left atrial appendage among patients with atrial arrhythmias. Here are just a couple of still frames. Here's a patient in apical 4 who has significant left ventricular dysfunction and has a late left ventricular apical thrombus present. Here's a patient in atrial fibrillation who has a left atrial appendage thrombus, same density as tissue, but dilated left atrium. And if you look closely, some minor spontaneous echo contrast material in the left atrium. Here's a moving picture of a patient who has significant left ventricular dysfunction with apical dyskinesis. And you can see this protruding mobile mass at the left ventricle, which is highly consistent with the presence of a left ventricular apical thrombus. Here's a patient who's had an anterior apical myocardial infarction. And I show you this because it's extremely important for your sonographers to go off axis to scan the apex. Here in the standard apical 4 view, the apex looks clear. No clear evidence for any mass. If you go just off axis a little bit, almost into an apical short axis view, you can see this mass in this area of akinesis, which is highly consistent with the presence of a thrombus. Some cases will require, sorry for that. Some cases will require you to use echo contrast material to identify apical thrombus. Here's a patient who has an akinetic apex, and you can see 2 filling defects at the left ventricular apex, consistent with the presence of thrombus. In terms of the right heart, Dr. Rudsky showed you a similar case. Here's my case of a patient who's had a massive pulmonary embolism. You can see that the patient has McConnell sign, hypokinesis of the right ventricle, dilated right heart, and you see this serpiginous cast-like structure, which is a cast of the veins, a thrombus in transit. And catheter-related thrombus is also common in the right heart. Here is a TE view, bicaval view, superior vena cava, a catheter entering the right heart, and the catheter extends too far into the right heart, and it erupts up the wall of the right atrium here, and you can see a thrombus on the right atrial wall. Thrombus can also be seen in catheters that are entering the heart. Here's one of a bicaval view, patient with an indwelling catheter for nutritional purposes, and you can see a large mass protruding from the catheter into the right atrium. This was a large thrombus. And here's a patient that we saw many years ago who presented with a cold, pulseless foot and a pulmonary embolism. And you can see this large thrombus trying to make its way through this patent foramen ovale to get to the left side of the heart, which explained his clinical symptoms. Vegetations occur at areas of endocardium opposite intracardiac shunts or prosthetic materials and on valve surfaces. Characteristically, they are found on the atrial surface of the AV valves and on the ventricular surface of the semilunar valves. They're highly mobile, independently mobile and oscillating. They have a tissue density that is different than surrounding tissue, and they generally cause some degree of valvular regurgitation due to tissue destruction. They may cause obstruction if they are large enough. They're generally infective, but also remember patients may have non-bacterial thrombotic endocarditis in inflammatory conditions or in oncologic conditions that can cause masses on the valves. And if they're chronic, they may calcify. So here's an example of a patient who's an injection drug user and has a Staph aureus bacteremia. And you can see the posterior mitral leaflet is involved by a mass that is independently mobile, oscillating between the left atrium and the left ventricle, and highly friable. And this is a large mitral valve vegetation. This is the TE. Oops. This just skips ahead. This is a TE on the same patient. And you can see how mobile, large, independently mobile this is, and how friable this vegetation is. Very high embolic potential. And Dr. Wiggers will talk to you more about endocarditis coming up. And here's the one case that I could find over the years of a patient who has a pulmonic valve vegetation. So this is the RV outflow view, pulmonary artery bifurcating. And here is an injection drug user who has a pulmonic valve vegetation. Again, highly mobile, oscillating back and forth, different tissue density. This patient has aortic valve endocarditis. So this is a aortic outflow view on TEE, and you can see, again, an independently mobile, shaggy mass on the aortic valve that has led to tissue destruction, and this patient had severe aortic regurgitation. It's also important to remember that about 10% of patients that have native valve aortic endocarditis will also have periannular extension. Here on the TE, you can see an abscess in the aortic root. And this is an example of a patient who has chronic or healed endocarditis. So the valvular lesion is calcified, and it's moving with the normal valve motion. Let's switch gear now and talk about the cardiac tumors. Primary cardiac tumors are rare. They're seen in about 0.02 to 0.03% of all autopsies. Most of them are benign, between 75 and 80%, and about 15% are malignant. Of the benign tumors, the most common are the myxoma and papillary fibroelastoma. Of the malignant tumors, the most common ones seen are sarcomas. Cardiac myxoma is the most common primary cardiac tumor. Most cases are sporadic, but in about 10% of cases they are familial. They tend to cluster in women, and they can recur and be multicentric. They're most frequently seen in the 3rd to 6th decades of life. They may arise anywhere within the heart, but characteristically, about 3/4 of them are seen in the left atrium, adjacent to the fossa ovalis, and they characteristically have a stalk. The clinical presentation can vary from an incidental finding on an echocardiogram for another reason to certain symptoms, constitutional symptoms, embolic symptoms. Approximately 30 to 40% of patients with myxoma will have an embolic event, primarily to the central nervous system, or obstructive type symptoms. Here's a case that we saw many years ago. On the left is the patient's transthoracic echocardiogram. On the right is their TEE. And you can see the characteristic appearance of a left atrial myxoma adjacent to the inner atrial septum. On TEE, you can see the myxoma is right adjacent to the fossa. Here's the fossa right here. I'm pointing with my arrow. And it's a very small stalk here. And what's important to realize is that 3-dimensional echocardiography will define this much better than 2-dimensional imaging. As you can see, the appearance of this myxoma is fairly homogeneous, and it is rounded and smooth. However, you could have thrombus on the myxoma itself, which may lead to embolic events. Here's a different patient who has a very large left atrial myxoma. You can see the nature of this myxoma is somewhat different. About 2/3 of the myxomas appear as that rounded nature that I just showed you. This is a more polypoid appearance to a myxoma, and this type of myxoma has a much higher embolic potential. This tumor is actually flopping right across the mitral valve, and this is the patient that would present with the classic tumor plop. And Dr. Kronzen, I believe, showed you this M mode yesterday, but it's worth reviewing. This is the M mode that is classically seen in a patient who has a myxoma that prolapses across one of the AV valves. And what you see initially, the valve opens, blood starts to flow in, and then you see the mass of echoes associated with the tumor. So you characteristically see this echolucent area before the tumor comes into the valve orifice, and then you see the massive echoes behind it. This is not mitral stenosis because the leaflets of the mitral valve are not thickened. Myxomas can also appear in other atypical locations in the left atrium. The most common is the anterior atrial wall, which is shown here. Here's a two-chamber view. Here's a mass attached to the atrial wall within the left atrium. And on TEE, you can see here's the mass again, and there's the very small stalk. So the stalk is characteristic in a myxoma. Myxomas can also appear in other cardiac chambers. The most common location outside of the left atrium is in the right atrium. And here's a patient that I've been following for many years. She presented from an outside hospital with progressive lower extremity edema. And finally, she had an echocardiogram performed, which showed that she had an extremely large mass within her right atrium. And you can see this is attached to the superior atrial wall. If you watch here, you can see it being pulled up as it prolapses into the tricuspid valve. This patient actually had a tumor plop if you took a good listen to her. And you can see on the color Doppler, there is obstruction to inflow. This is not the same patient. This is another patient I saw several years ago who had a large right atrial myxoma removed. This tumor is rounded. This tumor is very polypoid and gelatinous. And I show this to you is that these tumors can be potentially biopsied. You would not want to biopsy this tumor. This is gelatinous. Do not ever biopsy this type of tumor. Myxomas can also involve the cardiac valves, and there are several case reports. We saw this patient many years ago. Here's a myxoma that's attached to the anterior mitral leaflet. And this is the pathology at surgery, surgeon's view. So anterior mitral leaflet, posterior leaflet, here's the attachment point of this myxoma. So that brings us to our first response question. So which of the following primary tumors is most likely to involve the cardiac valves? Is it a myxoma, papillary fibroelastoma, sarcoma, hemangioma, or rhabdomyoma? Can we have up the responses? Go ahead and vote. Okay. Wonderful. Looks like 96% got the correct answer. It's the papillary fibroelastoma. So papillary fibroelastoma is the second most common primary cardiac tumor, but it's the most common tumor to involve the cardiac valves. Approximately 75% of tumors involving the cardiac valves will be found to be papillary fibroelastomas. Left-sided heart valves are more commonly involved, with the aortic valve being the most commonly involved. It tends to involve the aortic surface of the valve. And if it involves the mitral valve, it tends to involve the atrial surface of the mitral valve. These are avascular papillary fronds that are frequently pedunculated. They involve the mid portion of the valve and therefore rarely lead to valvular dysfunction. Their significance is that there's a very high risk for embolism, especially if they are mobile and especially if they have large size, say over 10 millimeters. This review from Gouda summarizes the literature up until the early 2000s, looking at the distribution of papillary fibroelastomas within the heart. And as you will see, that the vast majority of them do involve cardiac valves, the aortic valve and the mitral valve being the predominant valvular structures involved. But also remember that non-valvular sites can be involved. Grossly, they appear as a somewhat gelatinous mass at the mid portion of the valve, here the aortic valve. If you place these underwater, you get the characteristic sea anemone appearance. So placing this tumor underwater, here's the stalk, you can see all these little papillary fronds, and it has the appearance of a sea anemone. And if you look under low and high power, the histology to the right, you'll see that these are avascular fronds. How do they appear clinically? Well, here's a real-time TEE of a patient with a papillary fibroelastoma involving the left coronary cuspid aortic valve. And in this case, a little atypical, it appears to be on the ventricular side of the valve. Remember, they're more commonly found on the aortic side of the valve. Here's another case. This is a young man, you notice the date, 2008, who had a stroke. It was felt then that his heart valve was mildly thickened. He presented several years later with another stroke. And on the still frame, you can see on the moving picture, you can see the mass here on the anterior mitral leaflet, and it has this characteristic speckled, shimmering appearance. And I find that very helpful to identify that this is a papillary fibroelastoma. Here's a still frame. Here's a three-dimensional echocardiogram in the operating room showing the mass on the anterior mitral leaflet, and here's the mass at surgery on the anterior mitral leaflet before it was resected. Now, this long axis of the aorta shows a patient who has multiple papillary fibroelastomas. So the literature says solitary, but in about 9% of patients, they will be multiple in nature. And here is a non-valvular papillary fibroelastoma. So I saw this case, and I thought it would be a myxoma. This is a right ventricular inflow view. This is the tricuspid valve here. And this is a tumor that is attached to the tricuspid valve annulus, highly mobile, looks like it has a stalk. The pathology, this was a papillary fibroelastoma. Lambel's excrescences must be differentiated from papillary fibroelastoma. These are very common. They're seen in about 70 to 80% of adults. They tend to be multiple. As opposed to the papillary fibroelastoma, these papillary fronds are located along closure lines of the valves, and they rarely lead to any valvular dysfunction. They tend to be on the ventricular surface of the semilunar valves as opposed to the papillary fibroelastoma, which is on the aortic side, and they tend to be on the atrial side of the mitral valve. Here's a long axis TEE view of the aortic valve, and if you look closely right here on the non-coronary leaflet, you can see multiple little papillary fronds moving back and forth. These are Lambel's excrescences, and as you can see, there is no interference with the function of the aortic valve. Other benign tumors that you should know about for the boards include the rhabdomyoma, which is the most common primary tumor seen in the pediatric age group, frequently seen in children less than 1 year old. They tend to arise from muscle, but they can protrude into the cavity. They can be multiple, being in both ventricles and even in other chambers. There's a strong association with tuberous sclerosis, and what's important to realize is that in these primarily regress by age 4, and surgery is rarely needed to remove these tumors. So here's an example of a rhabdomyoma, and if we look at the moving picture here in a second, you can see intramuscular involvement in the left ventricle with protrusion into the cavity. Here we're rotating and sweeping into the right ventricle, and you can see involvement in the right ventricle, and here's a still frame showing this tumor in the right ventricle, the right atrium, and even in the left ventricle here. The second most common pediatric tumor is the fibroma. The fibromas tend to be hyperechoic and found within muscle. They more often involve the left ventricle than the right ventricle, and as opposed to the rhabdomyoma, they do not regress and have been associated with ventricular dysfunction in some cases and even arrhythmias. And in real time, here's an example of a patient who has a fibroma. Malignant primary cardiac tumors are much less common than the benign primary cardiac tumors. Most often they are sarcomas. 80% of the cases are sarcomas. The most common sarcoma found is angiosarcoma, and it is most commonly found in the right atrium. It's usually highly invasive. It may be associated with a pericardial effusion and oftentimes metastatic disease. Other types of sarcomas more commonly involve the left atrium, including undifferentiated sarcomas, rhabdomyosarcoma, fibrosarcoma, leiomyosarcoma, and osteosarcoma, which characteristically may appear to be calcified. Mesotheliomas comprise 10% of malignant tumors, and lymphomas are very rare. Primary cardiac lymphomas are very rare, comprising 3 to 5%. Here's an example of a patient who has angiosarcoma. On the left is the transthoracic echocardiogram. You can see this is a large, bulky tumor. It infiltrates highly into the wall of the right atrium. This patient did not have a pericardial effusion, but more often than not, patients do have pericardial effusions. And here's his transesophageal echocardiogram showing diffuse infiltration of the walls of the right atrium. And unfortunately, this patient's tumor was metastatic when it was discovered. Primary cardiac lymphoma is found primarily in patients who are immunocompromised, HIV patients, patients on transplant patients, patients on multiple immunosuppressive drugs. It tends to involve the right heart more so than the left heart, and you can see in this example extensive tumor infiltration into the right atrium, over into the interatrial septum, and actually back toward the left atrium. These patients often have pericardial effusions. This patient did not. They also may present with very nondescript symptoms, weight loss. This patient actually had a syncopal event. It was seen at an outside hospital and had a pacemaker placed. And she came in because she was feeling worse and worse and worse, and we made the diagnosis of a primary cardiac lymphoma. And they generally are aggressive B-cell lymphomas. Let's go to our next audience response question. So, which of the following tumor types exhibits the highest propensity for cardiac metastasis? Is it malignant melanoma, osteogenic sarcoma, bronchogenic cancer, breast cancer, or hypernephroma? Go ahead and vote. Okay. The answer is very good. Malignant melanoma has the highest propensity to metastasize to the heart. Let's go through the secondary tumors. The secondary tumors are much more common than primary metastatic tumors, at least 20 to 40 times more common, and they're found in 5 to 12% of all patients who die of cancer. And you must consider cardiac involvement in patients who have known cancer, who present with new cardiac symptoms, and often these patients have diffuse metastatic disease. Now, clinically encountered metastases most commonly are breast and lung because they are much more common. The tumors that have the highest propensity to involve the heart are malignant melanoma and lymphoma. These tumors may reach the heart through a variety of pathways: hematogenous or lymphatic spread, direct extension, or they may invade by various venous structures, the vena cava, especially renal cell carcinoma, hepatocellular carcinoma, and uterine carcinoma, or via the pulmonary veins. The pericardium is the structure most often involved, and most often you see a pericardial effusion. Then the myocardium and the endocardium may be involved. Least common is the endocardial or intracavitary tumor. Here's a patient who has metastatic breast cancer who presents with a very large pericardial effusion, but no obvious mass within the pericardial space. Here's a patient who also has a pericardial effusion. You can see this mass adjacent to the left ventricle, and this is a patient who has metastatic lung cancer. In this apical four-chamber view, if you look in the right atrium, you can see a wiggling kind of mass entering the right atrium. And in this view, the inferior vena cava comes in about here. Can't make that out for sure, but if you go to the subcostal view, you can see dilated inferior vena cava and a large mass entering the right atrium. And this was renal cell carcinoma. So the most common tumor that you see invading through the inferior vena cava is renal cell carcinoma, if they ask you that question on the boards. Here's a patient who has several mass lesions within the right atrium, a pericardial effusion. And on CAT scan, you can see the right atrial masses and also multiple lung metastases from this patient who has uterine cancer. This is a TE view focused on the right upper pulmonary vein. This is the left atrium. This is the bicaval view. You see some nice lipomatous hypertrophy here, by the way. But if you notice in this right upper pulmonary vein, you can see a mass invading through the right upper pulmonary vein and extending out into the left atrium. This is bronchogenic carcinoma. And here's a patient who has lung carcinoma, and you can see a large mass in the left atrium that interferes with mitral valve function. And this is the area that Susan showed you yesterday where the left lower pulmonary vein enters the left atrium. And here's the patient's contrast-enhanced CAT scan, the lung mass, and the mass invading through the left lower pulmonary vein and infiltrating into the left atrium. Here's the left upper pulmonary vein. Okay, we'll finish up with just a couple of extra cardiac masses. So it's always important when you look at your echocardiography to look just beyond the heart. And if you notice anterior to the right ventricle, you can see this layer of extracardiac tissue. That's not adipose tissue. That's a mass, but you want to see it in multiple views. So here is a short axis view at the level of the pulmonary artery bifurcation, and you can see this large extracardiac mass, this mediastinal mass. This is a patient who has Hodgkin's disease. So here's another mass. This mass is adjacent to the left ventricle and the left atrium, and it's moving independently. There's an associated large right pleural effusion. And we were a little confused on what this mass could be from its echocardiographic appearance. And it's important to realize that echocardiography can, in most cases, not tell you what the tissue histology of a mass is. So the CAT scan was very helpful in this patient. There's a very large left pleural effusion, and this is all atelectatic lung. So here's the AV groove, which is marked by this calcium within the coronary artery. Here's the same plane over here, and you can see that this is all atelectatic lung, not a tumor. And here's just another favorite that likes to show up on the boards. Here's a mass behind the left atrium in the left AV groove. Here's the descending aorta. Here's the left atrium, somewhat maybe compressed by the mass. And on this patient's CAT scan, this is a large hiatus hernia. Okay, I'll stop there, and thank you very much for your attention.
We're running a little early, and we do have a few questions for Dr. Teig. What criteria do you use to identify an aortic root abscess?
It would be
as a mass.
Yeah, so it would be an extra. So it would be an extra space outside of the aortic tissue in the contour. It may be homogeneous in nature. It also may have cavity within it. And just remember, it's very frequently present in patients who have aortic valve endocarditis. About 10% of patients, I would say, is very frequent. And it's much more common if you have a prosthetic valve.
Can you discuss the appearance of the crista terminalis on TTE, particularly in the four-chamber view?
Yes, so you can see the crista terminalis in the apical four-chamber view. That is, it's just a little protrusion into the chamber. It's not independently moving, and it's frequently confused with a mass. But if you just need to look at multiple views, it's frequently there, and it's also frequently confused with the eustachian valve, which Susan showed you a very nice picture of. That's more posteriorly located.
In terms of an apical thrombus, will a 10 megahertz probe help as the apex is more superficial?
Sure, yeah. So if you want to see superficial structures, that will help. Also, cone down, you want to just focus your, as Dennis Atherton said, move your focus up, take a look at the atrium, take a look at the apex, go through an apical short axis, do all of those things. You want to separate out, you may find a lot of trabeculations or false tendons there, and actually low Nyquist color ventriculography in my day was always a good thing. We still pull that trick out. And then to be really careful, contrast if you're not sure. And then if you're really not sure, call your friends in MRI and see if they can help you if you're still very suspicious that there's a thrombus there and you need to treat that.
Related theme. Do we need to treat incidental finding of an LV apical thrombus in a non-acute MI situation?
That's a great question because I just had that happen with one of my patients the other day. So in the acute MI situation, the incidence of thrombus is pretty high, even today in the area of reperfusions. I showed you between 4 and 12%. As you get farther away from the acute MI, the risk of embolization drops. So there is no randomized controlled trial to help you here. Most people would say after 3 to 4 months, the risk of embolization is low, and you do not necessarily have to treat that patient with anticoagulants.
Right. These two are relatively similar. The first is, can you reasonably rule out acute pathology like a vegetation or thrombus of the valves if no or minimal regurgitation is involved? And the other was, how do you differentiate fibrin versus vegetation on a pacemaker wire or valves?
It's really the company that it keeps, I guess, would be the best way to put it. So in terms of, let's take the fibrin versus vegetation on the valve. If the patient is not presenting with bacteremia, they're not toxic, I don't know what you would really do about that. You're not going. If someone has Staph aureus and it's infecting their pacer system, everything's got to come out.
Right.
So that's an important distinction to make. So you want to make sure that you know what the characteristics of your patient are. So if the patient's presenting in a toxic way and you believe that this, and you have blood cultures that are positive, you take that system out. Otherwise, you treat through it. If the patient is not presenting with bacteremia or symptoms of endocarditis, I would just observe that patient. I don't know what you'd be treating in that situation. Can you give me the first question?
Yeah, the second one was, how do you differentiate between vegetation or thrombus of the valve if there's no or minimal regurgitation?
Difficult to tell. Again, a vegetation should have independent mobility. It should have a slightly different tissue density. And again, it's the company that it keeps. If the patient is not bacteremic, I would just observe that patient.
For left atrial appendage thrombus, does it have to be the same density of the tissue, and how do you differentiate sludge from clot?
That's a good question. So first of all, it generally is close to the tissue density. Sludge versus clot. Sludge. So I've gotten fooled before. So in the operating room, I told the surgeon once, I think that there's a thrombus in the left atrial appendage, and he went in there, he looked, and it was all sludge. Sludge can be very difficult to separate out, and I will tell you that when we comment on sludge to our colleagues in EP who want to cardiovert somebody, they said, unless you can tell me 100% that there's no thrombus there, we're not cardioverting this patient right now. Sludge, generally, if you observe well enough and go through a full sweep of the left atrial appendage, Sludge, you can generally tell because it's kind of just moving back and forth slowly. It looks kind of I don't know how to describe it. It looks slow, gelatinous, moving back and forth. The mass is, I think you can tell if you have a good quality TE that there's a mass there. I don't know, Marty, what your thoughts on that are.
No, I would agree. I mean, you really have to, for very dense sludge, first of all, if it was me, I would say, please don't cardiovert me. But I mean, you do watch it over time, and if it's constantly changing, and you see a little bit of change in the morphology, again, you'd have to take long loops to kind of prove that. But again, it's a gray area. Truly dense sludge is very hard to differentiate from an actual formed thrombus, and I usually tell the EP folks, back off. Okay, one or two last questions. When a thrombus in the LAA is inconclusive, I give contrast, such as Definity. All of a sudden, I lose resolution even of the LAA, and I can see nothing. What is the reason, and what is the remedy?
That's a good question.
Yeah.
That's a tough one. In some cases, you can see the thrombus with the Definity. So the one key thing is just make sure you have the proper settings that are set for contrast. I don't know if you change your settings to adjust for contrast.
Right.
Using the heat of battle, you're just injecting it, and that may be not helping you.
Right.
Other than that, I don't have any specific thing to do.
Yeah, I mean, I think manipulating the mechanical index to the best of your abilities. Again, it's already low on TEE, but you may need to make it a little bit lower. It's a bit of an art form. I personally have had the same difficulty. I usually try and make my thrombus decisions without contrast. And for me, giving Definity or any other contrast agent certainly doesn't help differentiate sludge versus LAA thrombus.
Agreed.
And one final, bit of a fascinoma, but a final quick question. I just had a 41-year-old male with a clot of the left atrium due to ASD closure device placed 12 years ago. Is that common?
No, unless you have... I don't think I've ever seen one that far off. Usually they're endothelialized by 6 months.
Right.
That's very unusual, in my opinion. What was it, an Amplatzer type?
Yes.
That's extremely unusual. You know, the old NMT devices were much more associated with thrombosis than the Amplatzer
Right.
ones. That's a very unusual case.
Very good.